Good evening. Hello. I'm your host, Dorothy. Welcome to Egg Donation Friends webinar. Today's topic is implantation issues and hormonal reproductive defects. And our presenter today is Dr. Alexandra Izquierdo, Medical Director at ProcreaTec Fertility Clinic in Madrid, Spain. The presentation will last about 25-30 minutes, then the Q&A session will follow. If you want to ask a question, please type it in the chat section. Dr. Alexandra will answer your questions after the presentation. I would like to remind you that our webinar is being recorded and you will be able to view the video on our website. We will also publish the complete transcript of all the questions and answers. Dr. Alexandra, good evening.
Good evening to everybody.
I think if you are ready, we can start with the presentation. I just wanted maybe to get the confirmation from our viewers if they can hear us well. Yes. Okay.
Yes.
Okay, Dr. Alexandra. Yes, I think you can start. Fantastic.
Good. Okay, so pleased to be with all of you. Thank you very much to Egg Donation Friends for inviting me to this webinar. I hope I can give you some ideas on implantation failure, on implantation issues, and what it means, the implantation failure and the possible treatments that we can have. I know it's quite a controversial area, and many many studies have been directed versus this area, because once we have the perfect embryo, then the remaining issues about implantation are very important as well. So just to begin with the implantation issues, we know from the very beginning of assisted reproduction techniques, Dr. Rever Edwards said that the implantation is the last frontier that we have to go through in assisted reproduction. So it's true that once we have the embryo and we have the lining prepared, the intimate contact between them two has to be performed in order that we can achieve a pregnancy. So we have different interactions at this moment. We have the embryo getting in contact with the endometrium. Then we have the blood flow and immunology that affect that endometrium and that are interfering with this contact. And also the hormones that are preparing this endometrium so that it can be recognized by the embryo and the embryo can implant in that. So we're going to go through all these issues along the talk, and we're going to be able to see what the important in each step of the implantation are. So to start with the embryo is the main cause for implantation. If we don't have a good embryo, implantation won't be possible. We know that to have a good embryo, to have a blastocyst, we need a very high number of eggs. In average, when we have 10 eggs, we can expect to have 80% of fertilization rate. We can see about 6-7 embryos in day 2, 4, 6, 5, 6 embryos in cleavage stage on day 3, and then once we get to blastocyst stage, we know that up to 50% of the embryos will be blocked before that stage. And that's natural, and that's the natural selection, and that's good because we can avoid transferring embryos that we're not sure that they will be good or they will be blocked on day 4. So once we have these blastocysts, it's not that all we see in blastocysts is good. We have to also check about the genetic abnormalities that they can have. And that really depends on maternal age. We know that women under 35 have about 30 to 40% of abnormal embryos. But if we go above 42 years, we know that only 1 out of 10 embryos will be normal. And that means that we need a very high number of eggs to produce this number of blastocysts that will give a normal embryo. And this is the main cause for implantation failures in advanced maternal age, the embryo quality and embryo genetic quality. So genetic anomalies, as we said, are higher when we are in age. And that's the main cause for implantation rate, low implantation rate in advanced maternal age. but also is the cause of the miscarriage rate. So we know that even those embryos may have a couple of abnormalities that make them possible to implant, these embryos will be stopped, will be a miscarriage in the earliest month of pregnancy. And how about the hormones? Hormones are also very important so that the embryo can recognize the endometrium and can really produce this implantation between the trophectoderm, which is the outer shell of the embryo, and the lining. So we know that the endometrium has a specific endometrial window where where the embryo is able to implant, where the embryo will recognize the cells on the lining and will be able to get in contact and implant. This period is just after ovulation, between 7, 8, 9 days after ovulation, and we can track it with the hormonal profile in this moment. If we do embryo transfers in day 3 and day 4 and day 5, we need to have the endometrium within the same window of implantation. Otherwise, the contact won't be possible and embryos won't implant. So the first part of the hormonal cycle is produced by estradiol. The estradiol induces the endometrial growth, induces the endometrial demand so that it can increase in thickness and it can be prepared to receive the embryo. The second part, once ovulation has happened, we have the progesterone, which helps the maturation of this endometrium and will change all the production of hormones to help the embryo recognize the endometrium and then finally implant. So if the first part, the follicular phase where the estradiol is produced, is not properly done, then the lining will be thin and won't be able to produce a good luteal phase that helps implantation. So we have the estrogen activity for we have the estrogen activity for the first part and the progesterone activity for the second part of the cycle. We need to have this transformation so that we can really have a good implantation process. This transformation is related to the hormonal profile. And the hormonal profile is different if we go on a natural or in a substituted cycle. So we know that when we have a natural cycle or hormones have an interference with endometrial growth, the estrogens produced by ovaries are the ones that will affect the endometrial growth. And then once we have ovulation, the corpus luteum will produce the progesterone that will change the endometrium. If we go for an artificial cycle, all hormones will have to be included artificially. So we give estrogens for the first part of the cycle and then progesterone for the second part of the cycle. It's always possible to use a natural cycle when we do embryo transfers and use the natural estrogens for the endometrial preparation, and we'll see that afterwards as well. So the window of implantation is something really important. And when we do IVF cycles, when we go IVF cycle and we do a hyperstimulation of the ovaries, that may affect the hormonal pattern of the endometrium. So we know that when we have multifollicular growth, estrogen levels might be very high, and there's always this high risk of hyperstimulation syndrome. If that happens, we cannot accept that risk, and we have to trigger ovulation with analogs of GnRHA that will help avoid this ovarian hyperstimulation syndrome and will help to recover easily to a normal menses and a normal period. But the problem of this triggering is that that decreases the quality of the endometrium, and then we won't see an implantation because the second part of the cycle, this luteal phase, this window of implantation, will be altered to this agonist trigger. So when we do this agonist triggering, we see that endometrial growth factors may be reduced, and then we also reduce the risk of ovarian hyperstimulation syndrome. But we also reduce the possibilities of pregnancy. If we see some studies developed on the beginning of this analog triggering, the important thing is that we can avoid the hyperstimulation syndrome, which has been very severe for several years with this triggering with GnRH in agonist cycles. And we know that if we don't have ACG, external HCG, which is the orbital injection, there won't be an hyperstimulation syndrome. But then pregnancy chances are lower, and this is the problem here. We cannot do an embryo transfer when we trigger with analogs because the endometrium won't be prepared to receive an embryo. Pregnancy rates have been described to be very decreased when agonist trigger is done. So there have been several protocols trying to improve the endometrial quality after this agonist triggering, and some of them include HCG, high doses of estrogens and progesterone, but today maybe it's something that we don't risk to do. We prefer to freeze the embryos and do a substitute cycle after to avoid any secondary hyperstimulation syndrome due to the pregnancy. So when we do this agonist triggering, as I was saying, there's also the possibility of the rescue of this luteal phase, the estradiol patches, or some 1,500 units of HCG at oocyte retrieval have been used, but there's also a risk of non-implantation or a secondary hyperstimulation syndrome. We know with the studies we've done in donors that when we do this HCG, this agonist triggering, these progesterone levels in blood, as you can see in this graphic, are lower than those women where we did the HCG injection. So that's the reason why we don't see the same pregnancy rates for these women.
Dr. Alexandra, can I interrupt? Hello?
Dorothy, excuse me?
Yes, can I interrupt for a second?
Yeah,
Can I interrupt for a second? Yeah, I think
yes.
the sound is breaking up on your side a little bit. Can you please check that you have all the extra windows closed on your laptop? That should help, I think.
There's nothing. There's nothing open.
Nothing there. Okay, so maybe there's
No.
Okay, so if I could ask you maybe to speak a little bit slower because your voice is breaking up, so I think that will be better.
Okay.
Yes. Yeah. Okay, thank you. Okay, you can
Okay.
continue.
Okay. Well, I'll speak a
Sorry
bit
for that.
slower. So, okay. Thank you. No, sorry. Okay. So, recently, some of that there might be pregnancies even when progesterone levels are very low or lower than we thought would be necessary. So nowadays we have some new terms which consist on the individualization of protocols for the luteal phase support. So we try to see every patient as an individual to see how they develop during stimulation, how the uterus and hormones react to medication, and we decide in every moment which is the best option for each patient. So we see that the rescue of the corpus luteum was a possibility when we did the estrogen and intramuscular, excuse me, Dorothy, I think slides are going on its own.
Oh, I'm sorry. Is it okay now?
I hope. Okay.
Can you go
Yes.
back?
Okay.
Should be okay
Yeah,
now. Sorry.
I'm with this. Okay. So Maiden presented some articles where we recover the corpus luteum activity with ACG, but also with some intramuscular progesterone or estradiol patches. So we know that each one is different, and this is why we've seen sometimes pregnancies even with low progesterone. But regarding progesterone during stimulation, we know that when it's too high, it might also be detrimental. We know that if progesterone levels the day of ACG administration are higher than 1.5, that may increase the pregnancy rates. There's a big study conducted in Spain where they saw that after or beyond 1.5 picogram per ml of progesterone, that means that the endometrium may be ahead in receptivity than the embryos, and there might be that desynchronization between the embryo and endometrium, and pregnancy rates fall mm, uh, for, in a very important way if we go for an embryo transfer after that. Without looking at the endometrial, at the ovarian stimulation, so for any type of cycle, if progesterone is very high the day of ACG, we consider it's not good for the embryo transfer on the same cycle. And that's something we take into account also for egg donation cycles, where women do not undergo a stimulation, but they go on a substituted cycle, and we also control estrogens and progesterone to be sure that progesterone is always less than 1 or at least 1.2 to be sure that they are not producing exogenous progesterone that may interfere with implantation in the same cycle. So even if we go on a substituted cycle or not on a cycle with ovarian stimulation, progesterone levels are very important. And there's a study also that reflects this with genetics. So if we look at the endometrium of the genetic pattern of different endometriums the day of ACG, if progesterone levels are higher, the endometrial genetic pattern is different, which means attention, because maybe your endometrium at this moment is not receptive when you think it will be. So it's important that we take into account that progesterone has to be good enough for implantation, but at the moment that it has to be, not more that. This is the same study where they saw that these progesterone levels might affect the implantation, and they also saw that even with lower levels, less than 0.5 picograms per ml, the implantation rates may be reduced. So both extremes are difficult for the endometrium. That makes it not good for the implantation within the same cycle. And this is related above all with the ovarian stimulation, because substituted cycles tend to go very well. But with ovarian stimulation, we know that when cycles are long, when we have a long cycle, when we have a long stimulation, that may cause an important alteration of progesterone. Follicles start to produce progesterone prematurely, and that's what's going to impact on endometrial receptivity. So just a moment to talk about the estrogens, because we said before that estrogen, the treatment before the ovulation, the estrogen levels before the ovulation are also important to prepare the lining. And that's true because we need a specific thickness more than 6-7 millimeters to improve implantation rates. But we know that if estradiol levels fall more than 80% after the egg retrieval, pregnancy rate may also be reduced. And if we increase estradiol levels by oral supplementation, that won't change the result. So attention also when we see determined estradiol level, and some days before the implantation we look at it and it's down, then maybe it's not a good cycle to do the embryo transfer, because that may also have an impact, a negative impact on implantation as well. So regarding frozen embryo transfer, as we've been saying, if we want to avoid ovarian hyperstimulation syndrome, if the hormone levels the day of ACG administration are not the correct one, then we should freeze embryos and go for frozen embryo transfer, which give us an absolute control on the hormonal preparation of the endometrium, and which will tell us that we are really in the right way for the embryo transfer. Vitrification protocols nowadays are very effective, and we are sure that about 95% to 98% of the embryos that are frozen will survive after the thawing process. So that's something that helps us to make decisions in the sense of not taking the risk of using a cycle that where we're not sure about the hormonal profile. Cochrane Library have done this research about different regimes for the embryo transfer, and we know that there's no difference among protocols. So it depends on every woman. We can choose either natural cycle, we can use estrogen patches, oral estrogens, progesterone, vaginal or subcutaneous progesterone. So nearly every protocol can be done. That depends on the woman, that depends on how she reacts to the protocol. If we don't get the right endometrium with one protocol, we can always change to another, knowing that none of these protocols has showed a better result in terms of pregnancy rates or newborns. The only thing that we know, and since this study helps us know, is that if we have a estrogen treatment with a long duration, that may affect the implantation rate. So if we're going to do a stimulation, a substituted cycle, it's better to do it shorter than longer. So we can have until 20 days, 25 days of estrogen stimulation without a difference. But if we go beyond the limit of 1 month, 30 days, that may have an impact. The endometrium won't be as receptive. So there's no need to go beyond that limit. In terms of timing for the endometrial receptivity and to try to set the exact moment for the endometrium, it's important to know the day where our embryos are frozen and then decide the number of days of progesterone administration that we need to give to make it match the moment of the endometrium and the window of receptivity. So there are many studies conducted around this area, and finally we know that when we're going to do an embryo transfer on day 3, we need to start progesterone on day 0, which means 4 days before. If we're going to do an embryo transfer on day 4, for the embryo on day 4, we need to start the progesterone 5 days before, and then if we're going for day 5, then 6 days before. That's what our test will tell us. You have here some schemas on how to do it, and basically we start progesterone the day 0 in the morning, and then we do the embryo transfer on the day of the embryo thawing, and it's the same day that the embryo was frozen. So this is all related to window of implantation. We know most women are receptive on day 5, so that's why we tend to do plasticized transfers for day 5 of progesterone. Take it into account that we start progesterone on day 0. So most women are receptive within this window, and that's about 90% of patients. But we know that some patients may have this window replaced for before or after, and we need to know it if we have receptivity problems and we have implantation failures. Some women with implantation failures, we can do this test of receptivity where we look about 250 genes on the endometrium, the moment of the implantation, and we've seen that some women can be pro-receptive and some other post-receptive, which means that we have to do the embryo transfer some days before or after our protocol. And that's very useful because some women have this alteration in window of receptivity, and with this test we can really see very well where we have to do the embryo transfer. We are having very good results with the use of this test to assess the right moment. Not for every patient, but for those who have an implantation failure, because as I said, about 90% of patients are receptive when they have to be. So just to end up with these issues about hormones, the last information we have about the hormonal profile on the endometrium regarding implantation is a study conducted last year, and that told us that maybe the progesterone levels, blood levels, the day of the implantation, the day of the embryo transfer, are very important as well. And if we are under a certain threshold, there might be a reduced pregnancy rate. So that's something still new that we have to test, but it seems that there might be a relation with that on pregnancy rate. So we're also conducting a study to see whether we can improve endometrial receptivity by increasing the dosage of progesterone when we see low progesterone levels the day of the embryo transfer. We're going to move forward to blood flow and immunology. So this is a quite controversial area because many studies have been conducted, but they are very heterogeneous. They include very different patients, and it's very difficult to get some conclusions from these studies. But we know that maybe there's something there interfering with implantation, and it's fair for you to know what we're studying, what we're thinking that might have an importance, and what we're treating for some patients for whose we don't know what's going wrong with the implantation. So regarding thrombophilia and blood flow disorders, we know that the implantation process a good blood flow to the uterus. The mother has to prepare its body so that all the blood flow goes there to the endometrium and helps the first moments of implantation so that the embryo can grow and continue its growth inside the endometrium. So this thrombophilia testing talks about some blood flow disorders that may increase the thickness of the flow of the blood, that may cause coagulation problems, and that may affect the implantation during the first moment. We test many things about thrombophilia. These are some of the most important issues we do as tests for those patients with implantation failures or early miscarriages. And we try to see whether there's any alteration in any of those that may explain these failures. And it's quite surprising that some of the patients tested, quite a high percentage of the patients tested, we find an alteration that explains the previous failures. It's true that maybe these tests are not to do for everybody, but also as the implantation test for the receptivity, maybe for those patients that have implantation failures, we tend to do them because we can have some responses when all the rest is normal. So some studies have also given us these ideas of treatment. So we know that when some patients have recurrent implantation failures or recurrent miscarriage, helping with anticoagulant therapy or fibrinolytic therapy may help for implantation in the subsequent cycles. Of course, when we see that embryos are normal. So as we said, the main thing is the embryo, but when the embryo seems to be perfect and we still think there's something wrong, let's look at thrombophilia because that's something very easy to treat and that gives very good results. And then about the immune system, there are also some issues related to this, which is quite controversial because not many studies have the same results. So basically that would be related to the contact between the maternal cells and the embryo cells. So there are some patterns in maternal cells, in maternal natural killer cells, that may have a higher risk of killing a certain type of embryo, depending on the antigen that the embryo may express in the outer shell. So these studies try to relate HLA from the embryo and the KIR, which is the receptor of NK cells of the mother. NK cells are the natural killer cells, and these are cells that kill naturally any antigen, any external cell they may find in their body. So if we have NK cells very active with a specific receptor, this might activate the, the, the immune system to kill the outer shell of the embryo. So In these studies, they see that different combinations between the couple and the mother may be worse for implantation if we have a specific pattern on the NK cells, such as the B key pattern. That means that no matter which embryo we have, the implantation will be harder, and we need to have immunosuppressants to have this implantation. If we have a clear pattern, maybe it's worth looking at HLA from the couple to see if we can get a better combination in terms of couple and egg donor to see if we can improve implantation. But as you can see, all differences in terms of implantation and early miscarriage are very high, and this has always to be needs to be treated and documented by an immunologist that's very familiarized with this type of results and that can really help in terms of immunosuppressants. So as conclusions, I would say that implantation is a complex process where many factors are involved. The embryo quality is the main responsible for implantation, and then PGS may be recommended in case of recurrent implantation failure or advanced maternal age to avoid the embryo transfer of abnormal embryos that may be very frequent, as we saw before. Luteal phase is something crucial, and we are now in a moment of personalization treatment. So we reduce the risk of hyperstimulation syndrome with analogs and then freezing all the embryos, but then we can improve pregnancy rates with different strategies to prepare the endometrium. The luteal coasting, the personalized luteal phase support is important, but also all the protocols for the endometrial preparation we saw before, which are not different in terms of results, but we can be very different from one woman to another. So it's very important to find the right protocol for each patient. As said, frozen embryo protocols are equal. Progesterone levels the day of the embryo transfer may be relevant. We're still looking at that very carefully because that may change in the following months, or techniques of treatment or diagnostics the day of the embryo transfer. The window of implantation is very important, above all in those women with implantation failures. And of course, the anticoagulant treatment and immunosuppressant treatment may be beneficial in those patients with unexplained recurrent implantation failure and thrombophilic disorders. And that's all from my side. Thank you very much for your attention. I know maybe some of parts of this talk have missed because of the sound, but please don't hesitate to ask any questions that you may have now or after. I will be pleased to answer all.
Thank you, Dr. Alexandra. Yes, we have already quite a lot of questions. Okay, I think we can start questions and answer session. And due to some technical problems, if I could ask you to speak slowly, so I think it will be easier for us to understand the answers. Okay.
Good.
Okay, the first question is, I have had a very thin lining on the last 2 cycles. Could this be down to not enough progesterone? These were donor egg cycles.
Well, the thickness of the lining is mainly due to the estrogen therapy. So that means the first part of the cycle. In fact, when we prepare the endometrium for egg donation or for frozen embryo transfers, we look at the endometrium just only with estrogen therapy because it needs to be above 6 or 7 millimeters only with estrogens. In fact, after estrogen therapy, when we include the progesterone in the cycle, that may even be thinner, but it's not important. The main issue is the thickness before that. So if the endometrium doesn't grow properly with the estrogen therapy, That may be due to bad absorption of the medication or because there's a problem in the uterus, maybe adhesions or maybe a septum or maybe some problem in the uterus that's interfering with endometrial growth, but not really with progesterone.
Okay, thank you. Shall we go to the next question?
Yes, thank you.
How important is the regular monitoring of hormone levels, E2 and P4, during an IVF cycle, both fresh and frozen cycle?
Well, as I said during the talk, I think it's crucial because otherwise we won't know what's happening in your body, in the uterus, what are the hormones interfering with endometrium. If we have high estrogen levels, we know that these may interfere with implantation. If progesterone rises very early during the cycle, this may have an impact during implantation. So both estrogen and progesterone are very important to be measured. It's true that maybe it's not worth measuring them at every control, but at least at the beginning of the cycle, and of course the day of the triggering, is absolutely crucial to be sure what we're going to do next. And in a frozen cycle is the same. We need always to check the estradiol and progesterone levels before we start the progesterone administration to be sure that the progesterone levels are low before we start the external progesterone.
Okay, thank you. Next question. Can using estrogen tablets for over 30 days possibly lead to an early miscarriage?
Well, as the previous study showed, it referred only to less implantation rates when we use more than 30 days of estrogen tablets or administration without progesterone. So if it's only estrogen, we know that beyond 30 days, the endometrium may not be well prepared for implantation. So that can also explain an early miscarriage. If it's too early, maybe a biochemical pregnancy, that may explain that it can happen because the endometrium is not really prepared for giving a good result in terms of pregnancy.
Thank you. And next question. My progesterone level was 60 nanograms per milliliter on day of embryo transfer. It was a natural supported IVF cycle. Is this level okay, or is it too low or too high?
Well, the level is okay. Above 10 nanogram per ml, it's fine. So 60 is fine. It's absolutely fine. And we don't have a upper threshold. So even if we have 100, that's fine as well. The only problem if it's very low. So 60 should be fine.
Okay, maybe extra question. What's the highest acceptable level?
There's no upper threshold. No,
Oh,
no,
sorry.
no.
So maybe
There's
the
no
lower.
problem. No.
The
Yeah,
lower, the
that's only
worse.
the low. That's it. Yeah.
Okay, thank you. Another question from Nicola. My endometrium lining seems to thicken up okay, but the last few cycles I have had no triple layer. My local clinic described it as poorly defined. How important is the triple layer? Some clinics say thickness is the most important, some say the pattern is more important.
Well, both are important. If we have a triple line, but it's 4 millimeters, then it's not enough, even though we've seen some pregnancies with that. And also the pattern is important because if we have a triple line and 6 millimeters, it's absolutely fine. But we've also seen pregnancies with some distorted patterns. What I would say is why it doesn't have a triple line pattern. The main thing when we don't see a triple line pattern is to perform a hysteroscopy to see what's happening in the uterus, to see if there's something there interfering with the endometrial growth. And if we see something, then we can correct it. If we don't see anything, then there's the possibility of doing different type of protocol to see if the endometrium reacts differently. But unfortunately, we have many patients where we see the endometrium That's not triple line. But finally, some of them get pregnant. So we don't have 100% security that it's not going to work, but at least a hysteroscopy should be done.
Okay, thank you. Which cycle days are best for embryo transfer? Days 19 to 21, perhaps?
If that's a natural cycle, that's very difficult to say, and that's not a number. So basically, if the embryo is on day 5, we're talking about a blastocyst stage embryo, the best day for implantation in a natural cycle is 7 days after the triggering the ovulation. If we're talking about a substituted cycle, then it's on day 5 of progesterone, but always starting progesterone on day 0, which means 6 days before. So day 19 or 21, that depends on each cycle, and the best way to control it is to assess ovulation, to induce ovulation artificially, or to control it with LH surge, and then to decide the moment of embryo transfer. But it should be at least 7 days after LH surge. In those slides talking about the timing, there's also the timing for spontaneous LH surge, and it's well explained there. But I don't really recommend to do it in an absolutely natural cycle because it's very difficult and very uncomfortable to test LH surge every 12 hours to see if ovulation. Yes?
I'm sorry, Dr. Alexandra, I think the sound broke up for quite a while. Can you roll?
Yes. So I said that LH surge is very difficult to control. So if we can control it, then it's fine to do the embryo transfer 7 days after. But since everyone cannot say if it's 19 or 21 days after the first day of the period, it has to be controlled for every woman.
Thank you very much. Next question. I have been diagnosed with natural killer cells. I had 5 failed IVF and 3 natural pregnancies. How would you suggest the best way forward is? And we have additional information that these 3 natural pregnancies ended in miscarriage. This is the same patient asking.
Okay. Can I haven't noticed.
Yeah, this is the original question.
3 natural pregnancies. How would you suggest?
How would you suggest the best way forward is?
Well, that depends on. I mean, not all natural killer cells are bad. We do the diagnosis of natural killer cells, and then we see the type of natural killer cells, and that's why I said the immunologists should follow these patients because not all natural killer cells are bad. But normally, when we have these problems, and if they have 5 failed IVF, it should be important to see the embryo quality on those IVF because she's had 3 natural pregnancies with their own eggs naturally without any treatment, which is quite curious, and then 3 miscarriages. I think thrombophilia should be tested, and if natural killer cells are tested and are the bad ones, then a treatment should be encouraged with steroids to prevent this from NK cells.
Thank you. Okay, one more question about NK cells. Is NK cell testing best done by blood test or endometrium biopsy?
Well, that's a very good question. Normally, we have both, but it's not that there are many labs that will do NK cells in endometrial biopsy. So the best thing would be to have both to have an accurate diagnosis. But if it's not possible, then only the blood test would be fine just to start treatment. As I said, There are many immunological treatments that may be used, such as intralipids or immunoglobulins, but that's something that immunologists should talk about because I don't really think we have enough information to use them. Steroids is something we can control quite easily, and we can use them when we see an altered test in the blood. And also, we have some tests in endometrial biopsy that can talk about NK cells. But it's not that we have many labs that will do it, and not many patients have the opportunity to do them. If we have an alteration in NK cells in endometrium, we also have the possibility to use ACG or steroids to prevent any implantation failure.
Thank you. Next question. I have asked my doctor many times about testing for immunological issues, and he said that it is old science. I have a child from my own eggs, and I'm trying for a second child with donor eggs. I had one transfer, but that didn't work, and I'm trying again next week. And this is the next part of the question. What can I do to help my transfer? Taking Clexane plus estrogen will start progesterone suppositories and injections next week.
Well, the main thing is that we normally need to have a diagnosis to then. So if you've only had one embryo transfer, maybe it's just bad luck that you didn't get pregnant, so it's worth trying again. And then about immunological issues, as I said, it's quite controversial. It's normal that you may find some doctors that won't do the test because it's something that still needs a long way to be studied to give us a good tool to use with our patients. But if it doesn't work for a second time with egg donation and you've already had a pregnancy, why not maybe testing for the endometrial receptivity, for the window of receptivity on thrombophilia or immunology would be an option. But for the moment, if you're taking these estrogens, Clexane, and the progesterone, that should be enough for a second embryo transfer.
Thank you. A question from Catherine. Do you commonly use ERA testing? Can you explain more about that process?
Yes, the ERA testing is the test I was talking about in terms of window of receptivity. So we use it regularly when we have implantation failure. And it consists on doing a substituted cycle, estrogen therapy for about 15 to 20 days. Then 1 week with progesterone administration, 5 days, as if we were going to do an embryo transfer on blast stage. So the moment we take the biopsy, we send the biopsy to the lab, and they tell us the endometrial pattern, the endometrial genetic pattern that they've obtained at that moment, and if it's ready for implantation at that moment. We see that the studies they've performed, they say that 90% of patients are receptive. So it's not worth at this moment to do it for everybody, but we tend to do it for those patients with implantation failure to assess the right moment. And in those patients with implantation failures, we found many of them have a problem with the window of implantation, either before or after. We've changed our protocols for embryo transfer, and we have very good results with that.
Thank you very much. Question from Maria. What's the lowest level of estrogen and progesterone which should be given before the embryo transfer in a donation cycle?
Well, I understand is the blood level in a blood sample, not the dose of medication, I assume. So, estrogen levels should be more than 100 to be normal picograms, and progesterone should be more than 10 regarding the last study, the day of the embryo transfer, to be sure that everything will be fine. But this may vary a lot. We have patients with 150 picograms per ml of estradiol, and we have another with 1,000. So that's very different from one patient to another, for different in terms of absorption. But the main thing is that it's not very low. The progesterone is the same. We don't have an upper threshold, but we have this limit, this lower limit of 10 picograms, so that we can be sure that it will be fine for the embryo transfer.
Thank you very much. Next question. Okay, this is a long one. I have had 8 rounds of IVF. I found out if my 8th one has worked. I will find out if my 8th one has worked tomorrow. I'm 43 and have had 16 embryos transferred in total over the last 5 years. Only one implanted, but ended in a miscarriage. We did PGS for 1 cycle and it was tested as normal, but implantation still failed. I am at a loss as what to do next if this cycle fails. I guess donor eggs, but could there be other issues? I have had ERA testing and it was receptive.
Well, it's very difficult after all these embryo transfer. It's true that mainly most of these embryos could have been abnormal. When we have a genetic diagnosis and we don't have implantation, is very, very difficult to explain, but we see that even when everything's perfect, implantation is never 100%. So maybe it was just bad luck that this no embryo with the genetic diagnosis didn't implant. We know that implantation with genetic diagnosis should be around 70 to 80%, depending on embryo quality. And there's something that PGS cannot test, which is really the quality itself, the potential of the embryo to implant, the energy that embryo has to continue. So it's true that after 42, 43, it's very difficult to have a pregnancy with own eggs. If it's failed, it's very difficult, I assume, but maybe donor egg would be the option. You could go on other issues such as immunology or whatever, but maybe that's not the main thing. As we said in the talk, the main thing is the embryo. If we don't have a very good embryo, then other issues are not worth to be tested.
Thank you very much. Next question. Could uterine polyps affect implantation? I have a polyp larger than 10 millimeters.
Sure. I mean, polyps are in there, distorting the endometrium, affecting the cavity, and of course, an embryo transfer they perform if there's a large polyp in the cavity. So, without that, they should be removed. It's an easy technique, and it helps implantation a lot. So, yes, please do.
Thank you. A question from Lisa. I had a donor egg transfer, 3AA blastocyst, which failed. Lining quality was good. Progesterone was less than 10 on the day of embryo transfer, but only raised to 10.6 by negative pregnancy test day. Sorry. Day 10 later, despite 1.2 milligrams a day of estradiol. Was the level too low, and is there a better way of raising progesterone?
Well, the level is just limit. So it's, as I said, it's 9.5, 10 is the limit, the lower limit for progesterone. It's quite surprising that with 1,200 milligrams it didn't increase. So maybe the way of administration is not the right way, your absorption is not the proper one. So there's the way of using a subcutaneous or intramuscular progesterone trying to increase the levels. So that should be an option. And we know that when we use injections, progesterone blood levels increase a lot. Nevertheless, 3AA blastocysts it's a good blastocyte, but it's not top quality. So maybe the implantation or the pregnancy chances were not 70%, which is the average pregnancy rate for egg donation embryos, but it might be 50%. So you had a 50% possibility of getting pregnant or not. But just in case, I would suggest to go for subcutaneous or intramuscular progesterone for a following cycle.
Next question. While I am on hormones to be ready for transfer, how would you explain spotting? What does that indicate?
Well, that may have different explanations. The first thing to do is to be sure that the spotting comes from the uterus and not from the cervix, which sometimes happens. If it's from the cervix, then there's no treatment. It's something external and we don't need to treat it, and that won't have an effect on embryo implantation. But if it comes from the endometrium, from the lining, there's two possibilities. So either there's a problem with the lining in terms of there's a small polyp, they haven't seen additions that may cause an alteration on the endometrium, or the endometrium is not receiving the good dose of medication, hormones are not getting well the uterus. So in this case, it would be to assess very well the uterine cavity, maybe a hysteroscopy would be recommended, and then to try different protocols of endometrial preparation, different estrogen administration, oral, vaginal, subcutaneous, progesterone as well. So to change the different medications to see if you can react to them in a different way. But of course, checking before the uterus.
Thank you. We had a similar question before. This is again about the day of the cycle. Which day of cycle would be optimal for transfer for donor egg with a day 3 embryo?
So if we're going to transfer a day 0 embryo, imagine we're going to do the embryo transfer on Friday, then you should, on a Friday, then you should start the progesterone on Tuesday morning. So it's on day 0 in the morning, and then do the embryo transfer on day 3. So it's 4 days later.
I have been suffering with cold hands and cold feet, and this has been an issue especially after embryo transfers. All thyroid tests proved okay. I know this could affect blood flow to the uterus and possibly implantation. How could this be treated?
Well, before we treat, we need to know what's happening. So, as we said before, there are sometimes some blood flow, and many times we send our patients to an hematologist to check all the hematology parameters, all the thermophilia testing, to be sure that we're doing things well. And I think that should be an option to see if there's any reason for that, because maybe there's no reason that it's not related to implantation. But if it is, it might have a treatment. And the main thing is to see some specialist to be sure the moment you have to start the anticoagulant treatment, which anticoagulant treatment you have to follow, how you should control this anticoagulant treatment in terms of blood tests to check the levels of anticoagulation, and when you should stop it if you get pregnant, if you should follow it during pregnancy or not. So before we give you treatment, we need to have a diagnosis to be all treatments well done.
With diagnosis of NK cells, when should Bioven be used? I was given Bioven on the day of embryo transfer, but not after that.
I don't know what Bioven is. Maybe it's a name. I don't know. You can just give me a moment to check, and then I will give you an explanation.
Okay, so let's wait for the patient to tell us more. In the meantime, we'll go to the next question, and once I have more information, we'll go back to it.
Okay.
I have frozen embryos. Could I have them shipped to your clinic and have the embryo transfer there?
In terms of embryo transfers, it's important to check. I mean, we will have to check with the European Union. There shouldn't be a problem to move embryos. But it's important to check. What we tend to do is we talk between labs, and then the labs have to check the different protocols of freezing and thawing to be sure that everything will be compatible and that we will give you the maximum chances for your treatment. And then if the law permits to move the embryos and the protocols are similar, it's done.
Yes, I think if the patient is based in Europe, this should not be a problem
There
to
shouldn't be a
have the
problem.
embryos, yes,
Hmm.
transported to Spain. No, not at all. Actually, we have
Hmm.
had webinars on embryo shipping, and this can be done. Okay, next question. This is a follow-up question. What do you think of taking Benadryl? Can it hurt? If so, when to start and what dosage?
I don't know what Benadryl
Okay,
is.
so
All these names are different.
yes. So I'm just curious what country
Hmm.
y'all is from. If you want to share that information, please do so. That would be very, very useful, I think.
Yeah, I think
Okay.
if you want to ask about medications, maybe the best way to do it is just to let me know about the active principle
Active ingredient, yes. That's what I
yeah,
thought,
because
yes. The
yeah,
names
because
in
they
different
may
countries can
vary.
be different. Mm-hmm.
Yeah,
Sure.
some of them I know, but some others I don't. So
Not to worry, all those questions are noted, so our webinar participants will be able to get the answer. Do not worry, we will try to find it out for you. Okay, let's jump to the next one. Okay, I'm 54 and have had 5 donor egg embryos transferred with implantation failure. Everything prior to transplant was perfect. Why would embryo fail to implant? Okay, that's a very general question, but very, very um, important, I guess.
well, it's very difficult to explain sometimes why it doesn't work, but of course, it's important to look at the preparation protocols. I mean, even if we think that everything for the before the embryo transfer was perfect, we should look carefully at that. We should look at the endometrial preparation, hormones, and endometrial pattern. Also, as we said, the window of receptivity may be altered, so we need to check it as well. And of course, the embryo quality. We know that egg donation is a very successful treatment, but there's also the egg donor and sperms. And if the sperm is not fine, there might also be a problem with sperm. And, we have to look at it as well, and that may have an impact on embryo quality. So it's important to check everything.
Okay, thank you. Would you recommend an endometrium scratch, and does it increase the implantation success rates?
Some
We
patients,
cannot hear you,
we're
Alexandra.
trying
We couldn't hear
to
you. Can you start again, please?
find. Hello, can you hear me?
We cannot hear you. Now we
Can you
can
hear
hear
me?
you. Now we can hear you, but we didn't hear the answer.
Can can we hear?
I think the sound is breaking up. We cannot hear you right now. Hello.
Me now? Hello, can you
Okay.
hear me?
Yes, now it's better. Okay, I think we have some major sound issues or connection issues here. Okay, I think we have lost Dr. Alexandra. I can see it's not online. I apologize for the technical problems. It happens with live webinars, unfortunately. Sometimes we have no influence over such issues. Um, If you do not mind, we can wait just 1-2 minutes for Dr. Alexandra to connect again. And I hope she will be able to answer some of your questions. If not, it's not a problem that you can forward the questions to myself and we will get Dr. Alexandra to answer them. Okay, I can see the question about a copy of the transcript. The transcript will be published on our website. I can show you an example. We publish the answers to the questions in our news sections. Yes, thank you, Nicola, for understanding. Yes. Do not worry, all of your questions are already saved and me and Dr. Alexandra will have access to them. Okay, I can see Dr. Alexandra is already online and she's setting up her microphone and hopefully we'll get connected again soon.
Hello.
Yes, hello.
Oh, sorry. I don't know what's happened. I just tried to reconnect everything to be sure that you could
Yes.
hear me. Can you
Okay,
hear
we
me
lost
now?
you. Yes, okay, so you're back. Okay,
Sure.
let's try again. Let's try again about the question about the
Okay.
scratch.
Okay. So basically, we're conducting a study on the endometrial scratch to be able to focus these technical patients that will really have a benefit for that. It's quite controversial. There are many studies which say it's beneficial, some others that say it's not beneficial. So our studies conducted in egg recipients to avoid any problem with embryos that may affect the pregnancy rate. And we're seeing some differences, and we hope we can publish something by the end of this year to see which patients are really have a real benefit with this. But what we think is that there won't be a harm. So if there's a possibility, why not? It might be done.
Thank you. Okay, one more. I'm 38 years old with AFC around 11. I had 2 fresh and 1 frozen IVF with my own eggs that all failed during implantation. Should I try egg donation?
Oh, that's very difficult. Well, 38 is not that old, so and AFC 11 is not that bad. So maybe there are many other things to check before going egg donation. Just not to go to egg donation and find we have the same implantation failure problems. I would ask some other tests. We've been talking about hematology, immunology, to try to improve the um, the ovarian stimulation to maximize the number of eggs, and try a frozen embryo transfer, maybe with genetic diagnosis if we have good blastocysts. Of course, going to blastocysts before the embryo transfer, that's absolutely crucial. But I think maybe egg donation, it's always there. I mean, you can do egg donation next year, in 2 years, but if you want to try with your own eggs, it's now or not. So it's a difficult question. I would say try to look at other things, and if everything's normal, try and do another cycle with your own eggs to see if you can get good blastocysts.
Thank you very much. Is there an age limit to do IVF with donor eggs in Spain? I
Well,
think the question is about your country.
yeah, it's not a legal issue. Yeah, there's no legal limit in our country, but we normally don't do these treatments beyond 50. So there's this limit for all clinics in Spain that we tend to avoid treatments after 50. But it's true that it's not a legal limit. It's a
Okay, so
recommendation
maximum
of the
age
Spanish.
would be 50.
That's it.
Okay. Should I have my fibroids and cysts removed? I've had 8 failed cycles and 3 were donor egg one.
Well, that depends on the size of the fibroids and the localization of these fibroids and cysts. If we have small fibroids and they're not in contact with the cavity, then there's not a need, because if we remove a fibroid, we're going to leave a scar, and that won't help for implantation either. But if we have a fibroid that's just in the uterus, inside the cavity, or that has a very large size, it's better to remove it before going for a cycle. And in terms of cysts, that depends on the type of the cyst, because there are endometrial cysts that can be removed if they are very big. But if they are small cysts or functional cysts, they might not be removed, and there's not a need, and that might not increase the pregnancy chances. So basically, depending on the number of the size and the nature of fibers and cysts, they should be removed or not. So that is your doctor that has to take your case, and there's many publications about that in the literature, and they have to give you the recommendation regarding that study.
Okay, thank you. I think the connection problem is back, so if I could ask you to speak a bit slower, that would be much, much better. Thank you. Next question. Do you allow to transport frozen embryos from your clinic to another one in a different EU country, for instance, Poland or Czech Republic?
If, as I said before, it's possible as long as the law permits it within Europe, and of course, if the frozen and freezing protocols are compatible among clinics, that shouldn't be a problem. It's always the lab that gets in contact with the clinic recipient, and then we try to assess patients on what to do.
Thank you. Do you recommend EGA testing with the first embryo transfer with donor eggs? What tests do you recommend in order not to risk to lose the embryos? We had 10 IVFs with own eggs, low quality embryos, and never a blastocyst on day 5. Maximum on day 5-6 was a poor morula. Do you recommend EGA testing?
I don't really, well, maybe we could recommend it for everyone, but it's true that it's a cost. It has a cost, these tests. So, and we have to do a substituted cycle. So that really depends on if you can plan it or not. Maybe in the future we will do it for every patient, but for the moment we try to do it only for those patients with implantation failures. If you've done those embryo transfers but with bad quality embryos, then maybe we're not talking about implantation failure, we're talking about IVF failure, which is quite different. In order not to risk to lose embryos, that's very difficult. Of course, we can do all this thrombophilia testing and immunologic testing and to check all hormones, but maybe it's not necessary. It's the same if you have a headache and you go to the emergency room and you ask for an IRM, and it's not an indication, a medical indication. So we don't tend to do all the tests before we start a cycle. Of course, you don't have a diagnosis of implantation failure, so it shouldn't be necessary.
Thank you very much. What could be done with depression after embryo transfer on during an IVF pregnancy? I had struggled with depression during my last 3 embryo transfers. I managed to get pregnant during my 10th transfer, which was a donor egg IVF, which resulted in a pregnancy, but the fetal growth were behind, so no heartbeat was detected. Could depression be the cause of the miscarriage?
Well, not really. I mean, only if you were taking some medication that may interfere with pregnancy, but I assume it was not the case since you've done a treatment. It's not a spontaneous pregnancy. So the most likely explanation for this is there's a problem with either with the embryo, either with implantation, but not with all the depression.
Thank you. Dr. Alexandra, we have about 5 more questions. Are you ready to answer? Yep.
Yeah,
Okay.
that's not a problem. Okay.
Thank you. When is an endometrium scratch recommended before an egg donation cycle? The cycle before egg donation is a pill cycle. On which day or how many days before the egg donation cycle should be the scratch performed?
So basically, we tend to do it about a week before we stop the pill. So if with the previous cycle to egg donation is done with the pill to synchronize the donor egg, the egg donor and the recipient, then we stop the pill at a certain to start the cycle. So we do the scratch 1 week before that.
Thank you. Short question. Do you recommend embryo glue?
Well, embryo glue is a trademark of a specific liquid or culture medium where we put the embryos before we do the embryo transfer. It has a high hyaluronic acid proportion, so it helps the embryo attach to the endometrium before or during the moment of the embryo transfer, and then that helps for implantation. We tend to use this culture media that's rich in hyaluronic acid for all embryo transfers because we think it might help. We used embryo glue for a while, we tested and we found no differences in pregnancy rates. So for the moment, we try to use a conventional pre-transfer medium that contains this hyaluronic acid, but it's not specifically embryo glue. Just to say that there are many different culture media that may do the same.
Thank you. Question from Katya. Can MTHFR be a cause for an implantation failure? I'm 34 and I have 3 fresh and 2 frozen failed cycles with PGD normal embryos.
Well, if it's homozygous mutation, it might be a cause. If it's heterozygous, it's less likely to be a cause. But of course, if it is there and after all these failures, normally I think that any hematologist would recommend a treatment for that. Of course, after all these implantation failures with these normal embryos and regarding your age, maybe that has an impact on implantation, so it should be treated.
Okay. This is again a question about medication. Dr. Alexandra, are you able to answer this?
I don't know. I don't know about this medication that's prescribed. I should have to look at it. I don't know. Maybe I can look at it and then answer by email if that's fine.
Okay, yeah, that will do, I think, yes. Okay. I still have 4 frozen eggs. Is it better to use one which is BB or an AC embryo?
Well, that's something that biologists should ask because it doesn't all depend on the day 5 quality. It depends on all the development of the embryos during the time they've been in the lab. It's not if during the first days one of them looked better or worse, or they developed different in a different way and with a different number of cells. So when we have doubts about day 5, we should look at the previous days, and that's something that your biologist should tell you.
Thank you. And we have one more question about medicine. Benadryl is an antihistamine medication. I think the question was, let me pull up the old question. trying to find the original question.
Mm-hmm.
Yes, this is the original question. If you prefer, you can answer by email if this requires some research.
Yeah, because I mean, we don't have experience with antihistaminic treatments. If it's a treatment you're doing for your own health, we know that some antihistaminics can be taken during pregnancy, and that's why we recommend to patients. If that's something they've recommended for the treatment itself or implantation, I have no idea. I haven't seen any studies regarding that.
Okay.
Mm.
Next one. If my thyroid is 6.6, should I be on medication before considering IVF with donor eggs?
I assume that's TSH level, and of course, if it's 6.6, it's very high, and she should be on treatment to try to reduce it less than 2.5, because that's the level we tend to have or we tend to look for before pregnancy.
Follow-up question from Lisa. I have one 4BB embryo frozen after failing with the 3AA. Is it worth transferring this blastocyst or trying to get better blastocyst from the same or another donor while considering the progesterone levels?
I think if you have an embryo frozen, you should go for it. You never know if it's the embryo that's going to give you the pregnancy, and you shouldn't go ahead with a new cycle. Of course, I know it's difficult sometimes when we have embryos that have a lower quality, but 4BB is a good embryo, and of course, I think you should go for it. You never know. Many embryos, different qualities implant, so it's worth going for it without that.
I hope Lisa will be lucky this time. Fingers crossed. Okay.
Yes.
And all of you, the rest of our um, viewers. Okay. Do you recommend taking
Mm.
melatonin to improve egg quality?
That's very difficult. Some studies say that it might improve egg quality. That's very difficult to say. So it won't be bad for egg quality. It won't do any harm. But I'm not 100% sure that it will improve egg quality. So be cautious with this. You can take it, but do not expect to find a 100% change with this.
Uh, do you recommend to lower thyroid levels prior to starting IVF cycle? My level is 3.1 and my obgyn states that it should be lower than 2.
Yes, as I said, normally we tended to look for it less than 2.5. Some obstetricians say that less than 2. It also depends on the antibodies, thyroid antibodies, but less than 2 points what we expect to have here.
Okay. Why is the ferritin depot shot administered before donor egg procedure?
Well, that's not 100% necessary, but some protocols do to avoid any follicular growth during the procedure, during the actual procedure treatment. Because when we're doing the synchronization with the egg donor and the recipient may produce some follicles and spontaneous growth, and that might interfere with the hormones during the cycle. So that's why we try to give it, but it's not 100% necessary.
Thank you. I think these are all of the questions for today. Oh, there's one more. I'm doing an overseas transfer. Can I fly after my embryo transfer? the flight is less than an hour.
It shouldn't be a problem. Many of our patients come from different countries in Europe and they come in the morning, we do embryo transfer by midday, and they come back home in the afternoon or late that night, and there shouldn't be a problem. Um, we know that embryo transfer, we normally give some recommendations after that, but activity can be continued as normal. The rest is not absolutely recommended.
Okay, so what if the flight is over 10 hours, 2 days after transfer? Is it still okay to travel?
It's the same. It's the same. The only thing is that since patients will have many hormones, sometimes we add some anticoagulant for the time of the journey because it's quite long and to avoid any risk of thrombosis. But that's the only thing, but not for the journey itself.
Okay, for those viewers who didn't hear the answer, yes, you can travel after the embryo transfer, and it doesn't matter if the flight is 1 hour or 10 hours. Is that correct?
That's it. That's
Yes.
it.
Okay. Yes. Okay. Fantastic. Okay. No problem. Thank you, Katya. Uh, okay. So, do you recommend rest after embryo transfer or
No.
moderate activity?
Moderate
Not really.
activity, continue normal life. No, no rest.
Okay, so there are quite a lot of questions now. Daily driving, yes, after embryo transfer.
Normal.
Same, no
We can
problems with
continue
that.
normal life. There's no problem. About swimming, I see a question there also. We only recommend to avoid 1 week of immersion, but besides that, afterwards they can continue swimming with normality.
Okay, so 1 week, it's not for 1 week. It's not recommended to swim in a pool.
Yeah, not for 1 week, but after that it's fine.
Mhm. Okay, we have one more. I have asked about low hemoglobin. Does it
Hmm.
affect implantation? I have HB of 11.7.
Well, that's not very, very low. It's a bit low, but it shouldn't affect implantation. As long as you live normally with that. If there's a problem that has caused this reduction in
It shouldn't.
hemoglobin,
Okay.
it needs to be treated. But if not, it shouldn't be a cause for implantation failure.
Question about diet after embryo transfer. I have seen many questions that comment anything, or it does not influence the results that much.
No, it does not influence at all. No, nothing. Eat what you
I think
like, what you
it is a
want, what
myth.
makes you
It
feel
is a myth.
good.
Yeah, pineapple or no pineapple. So
Yeah, no, no. Eat what makes you feel well and relax because, of course, the days to wait until the blood test for pregnancy are very hard. So no need to look at what you're going to eat or drink or whatever. I mean, of course, no alcohol or not a lot of coffee, but that's all.
thank you. Okay, I could see a question about sending the link with the transcript. We usually do not send a link, but you can read the questions and answers in our news section, and I have included the link in our chat. Um, the questions and answers should appear within a few days, and you will see that on our social media as well. Okay, I think we have one or two more questions. Does gluten intolerance affect implantation? If I suspect gluten intolerance, shall I go gluten-free before the transfer?
Of course, the gluten intolerance maybe is autoimmune disease, an autoimmune alteration that may increase inflammation in your body. So if you feel that you might be intolerant, maybe avoiding eating gluten during the period of treatment and implantation should be fine. But just for the all the rest of things, so avoid doing any harm to your body that may affect your health in general and also implantation.
Thank you very much. I think this is the last question for today. Mm, okay, whenever I say it's the last question, there's one more popping up. No problem. I think we can do one more.
Mhm.
Okay, I have still 4 frozen blastocysts in 2 straws. Should I rather, okay, I think there's something missing here. Should I rather transfer 1 straw with blastocysts 3AA and 3AC? Okay, I'm a little bit confused by the question. Dr. Alexandra,
Mhm. Yeah.
can you
I
answer
think she's
that?
wondering which of the two straws is should she sew because she has 4 different blastocytes. But as I said
Okay,
before, with the question of the embryo quality, she should ask the biologist about the whole development. Embryos is not just day 5; it's all the previous development that will tell you the quality of your embryos, and then they will tell which is the best option to get pregnant with the first article you use.
thank you very much. Okay, I think that's all for today. Dr. Alexandra, thank you very much for the presentation, very informative. I have learned a lot as well. Thank you for answering so many questions. I know this is very, very hard work. And dear participants, dear patients, thank you very much for being with us. We know these issues are very difficult sometimes, and we appreciate your honest questions and your interest. And I hope you will join us in 2 weeks' time for our next webinar. And please stay tuned for the questions and answers. If you follow us on Facebook, you will definitely get the info about the transcript publication. Once again, thank you very much, Dr. Alexandra. It was lovely to have you.
Thank you. Thank you, Dorothy.
Okay. So if anyone is interested or wants to ask an extra question, you can email me and we will try to help you via email. Okay, I will now download the questions, so it's very easy for us to transcribe them. Okay, thank you very much. Good night.
Thank you. Good night.
Good night.